Good afternoon, everybody. Thanks for joining us. What a treat we've got in store. In this cardiology session, we're going to take a deep dive into some ECGs and take a look at STEMI, and we've got two of the very best speakers lined up for you right here. I'm not going to steal any of their time. I'm going to give you an introduction to the first speaker right away so we can get on with things. It's somebody I'm sure you'll know if you've been following the Eusem congresses. It's David Carr. He's an emergency physician and an associate professor in emergency medicine in Toronto, one of our keynote speakers last year. So over to you, David. I can't wait to hear what you've got to say.
Thank you for the introduction, Rick. Just going to wait for my slides to pop up. Excellent. Okay. Just waiting for those to load. It's great to be back. I certainly am missing hanging out with all of you in a live fashion. What I'm going to say is I'm going to talk about Stemi-Ish. Contrary to what Rick said, I'm not going to talk about STEMI. I know that you have Stephen after me who's going to hit this out of the park. What I want to do is talk to you about non-STEMI or Stemi-Ish. And what I want you to do, and I have this amazing technology, three times I'm going to ask you, as loud as you can, 6 feet or 2 meters apart, I'm going to call on you to ask the answer, and I'm going to hear it even though I can't really hear it. So I'm going to ask you, when the nurse shows you this ECG, and he or she says, you know, Dr. So-and-so, nurse practitioner so-and-so, how would you manage this patient at your shop? So at the count of 3, I want you to say what you would do for this person. 1, 2, 3. Okay. Well, I want to break it to you. We actually don't manage EKGs. We manage patients. ECGs are only one part of the puzzle. Rick likes troponins. He likes biomarkers. That's one piece of the puzzle. Stephen likes cardiograms. He's going to teach you all about that today. What I'm going to teach you about is a story. Now, let me tell you something about a disclosure. I have average POCUS skills. I'm not the world's best ultrasound guy. I often lie about my findings of JVP and fundoscopy. And quite frankly, during COVID, I barely examine patients. But what I do is I take a good history. And what I want you to know is, how does it feel? How are patients doing? And do they really have a STEMI? Because what I want you at the end of this talk is to find out what a STEMI looks like and walks like. If it looks like a duck and walks like a duck, it's probably a duck. If it's not a duck. And that's what we want to do today. So I got one thing I want to get off my chest. I Google search Levine sign. Now, if you Google search Levine sign, you'll see all men crushing their chest, looking to be in the most discomfort that anyone's ever had. But if you Google search Levine sign in a woman, you see this calm, serene, gentle woman with her hands crossed like a butterfly, all sweet. It's time to change this ridiculous mold. It's time that we change it, and I want to show you how. There was a study called the Virgo study, a variation in recovery and the role of gender and outcomes between men and women, young men and women between 18 and 15 with acute MIs at 100 hospitals, 2,000 women, 1,000 men. And most importantly, what they found is when men and women come with an acute MI, 95 and 97%, they come as a predominant symptom with chest pain. That is typical symptoms of MIs in men and women. They're actually pretty similar. But when we take a deeper dive on the gender factor, women endorse more symptoms, maybe some palpitation, maybe some nausea, maybe some epigastric pain versus men. Women tend to downgrade their own symptoms. 20% will say they have this, must be anxiety. Where 21% of men will say, oh, it's probably a muscle because I've been at the gym and hurt my chest. And 30% of women sought a provider to care for a similar complaint recently. And more than half of the time in the female category, the doc felt it was non-cardiac. We have a problem. The problem is that younger women have a higher risk of dying from acute MIs, and that we need to get rid of these gender differences. We need to start realizing that men and women are typical, and we need to be masters in looking after men and women because we need to understand them differently. Okay, I had to get that off my chest. I want to change gears. I'm living it. I'm loving it. How stupid was McDonald's to have an ad that shows the golden arches preceded by, some P wave abnormality and then a short run of non-sustained VTAC. Anyways, I have no disclosures. Just putting that out there that if you're having a Big Mac with large fries, maybe if you have that little run, it's the golden arches and maybe it's not VTAC. Okay. I told you today, we're going to talk about stories. We're not going to talk about ECGs entirely, but I kind of lied. But I want to tell you a story about a 73-year-old I saw about 5 years ago. She was waiting to have a Whipple's procedure for pancreatic cancer in my hospital on the Monday of her appointment. She came into the emergency department tachycardic, hypertensive, and hypoxic. And interestingly enough, she was totally fine when she woke up, but felt profound shortness of breath. And she came to the hospital by taxi. And I love people who come by taxi. Starting to hear a little bit of an echo, if we could just turn off mics. So she came in here and I heard her story, and her story was not ischemic. You don't become hypoxic, especially when your chest x-ray looks like that. So this is her cardiogram. Try number 2. I'm going to count to 3. We're going to turn all of our mics off because someone's is on. And what I want you to do, that's much better, is I want you to shout out at the count of 3 what her diagnosis is. Remember, 73-year-old, most thrombophilic cancer in the world, comes in, hypoxic tachycardia, 1, 2, 3. Fantastic. Really, I only heard pulmonary embolism. And that's wonderful because when you think about STEMIs, you actually have to take a story. And it's possible, when I even signed this ECG, I think I circled AVR. Yeah, AVR is up, but the story doesn't fit. So let's take a dive and look at pulmonary embolism. And the first is a study of 6,000 patients. 350 of them had a confirmed PE in an emergency department. 29% of those were tachycardic. 10.5% had T-wave inversion in their precordial leads. Almost 9% had the classic S1Q3T3, and almost 5% had an increased right bundle branch block. What does that teach us? Well, we kind of put this all together and did a meta-analysis of 10 studies, looked at 3,000 patients, and we kind of say, okay, well, there's these cluster of ECG findings that are crappy, and when you look, it's not just they're crappy, it's they have significant odds ratios for badness. Look at T-wave inversion, your ST elevation, being tachycardic. These are not just things to show off to your friends. It's wonderful that you have the knowledge when you pick this up, but you need to respect the EKG because the EKG predicts clot burden. When you look at the EKG, those findings that I show you are specific for severe pulmonary hypertension and bad cardiac output. So when you see those, it's not just saying, hey, yeah, Dave, I think that's a PE. It's, Dave, I think that's a PE, and he or she looks really sick, and I'm really concerned about them. So because this is a Stemi-Ish talk, in the last 5 years, there was this real push about ST elevation AVR. And Amalma 2 was really big on this, and so were others, that we were missing this forgotten AVR lead that no one talked about. It's kind of akin to when you used to see new left bundles, and you called the cath lab, but that new left bundle was eating Cheerios and on their iPhone and looked like a peach, and clearly they weren't a STEMI. Sometimes when you see ST elevation, you should get bothered. But this study looked at about 100 patients with ST elevation. A third were ACS, a third were tachyarrhythmias like hyper-K, and a third were non-cardiac states like PE or shock. And only in 10% of them was a culprit lesion identified. So that ST elevation, even in the AVR, doesn't necessarily trigger a cath lab. You have to think Stemi-Ish. You have to think about other possibilities. Here's a lovely study that I like. Looked at 100 PEs and 250 cases of LAD ACS. So it's PEs pretending to be LAD ischemia. And I love this paper. And what they found is when you look at the PE group, the S1Q3T3 did not exist in the ACS group. That right axis deviation did not exist in the ACS group. And that T-wave inversion in 3 and peak negative T-wave inversions in your septoprecordial leads were very specific for a PE. What you need to do is you need to group your Stemi-Ish together when you're thinking PE and not be fooled to think it's LAD disease. Let's go back to this ECG. This is the person that we saw together. And when I listened to you, you all screamed PE. You saw that AVR ST elevation. You didn't call the cath lab because you saw S1Q3T3, you saw the right axis deviation, and you saw the T-wave inversion in lead 3. These are key elements for you distinguishing between PA and ACS when it's trying to fool you into LAD disease. Here's another great 50-year-old, short of breath, hypoxic, long flight to Hong Kong. When you look at this ECG, you see that ST elevation in AVR, but what you also see here is S1Q3T3. You also see what I love to say is you see the V1 T-wave inversion, and you see it in the precordial leads, and you've all been taught to think Wellens. But when you see what you think is an ACS LAD Wellens, and you see T-wave inversion in lead 3, that Wellens +1, you need to think PE. But the most important thing you need to do is take a story. Take a story. Are they having a PE or an MI? Is this a STEMI or is this Stemi-Ish? Let me show you another ECG. Just to date how old this ECG is, I actually wrote in cursive back then, which is, I think, like hieroglyphics for today's generation. And this one, I was so sure had a STEMI. I wrote ST elevation in 1 and AVL. They had a troponin. But when I looked at the person, it was like end-stage manthrax. It was like a man cold. He was 30. He had nothing. I don't even know why we even did the EKG. That's not a STEMI. And 12 hours later, his ECG, double click. Let me just go back. 12 hours later, his ECG had normalized and he just had a mild case of myo. We don't treat EKGs, we treat stories. How about this one? Christmas 2005, a great chance for the world's religion to unite and take care of patients while those celebrating can celebrate Christmas. It also sucked to be this person with those tombstone ST elevations inferiorly with precordial leads. There was a problem with this guy. This guy had significant chest pain that he was screaming in pain and screaming in back pain. Now, this guy dissected. This guy didn't look like a STEMI. He had colicky pain. He just couldn't get comfortable. He was fidgety. He had a renal colic of his chest. That's not a STEMI. He was a dissection. And, before we used to give, in the days of us who still give thrombolytics or used to give thrombolytics, we did a damn good job of making sure we didn't kill people with dissections. Now people go to the cath labs. Well, sometimes we don't think about dissection as much. 24% of dissections have a trope. You can't just have a one-size-fits-all when you see ST elevation. You need to listen to your patients. You need not to treat ECGs. You need to treat patients. And you need to become master story listeners. How does it feel, as Dylan would say? That is key. So I want to change gears. I love acronyms, and I think this is a super important acronym. MINOCA, an MI with non-obstructive coronary arteries. And what MINOCA does is it rules out all the crap I just told you about. It says, okay, we understand that PEs and myocarditis and things like Takasubos, they don't count. But there's a subset of people who present Stemi-Ish or MINOCA. And they tend, if you looked at about 3,000 angiograms for ACS, it's about 5 to 15% of acute MIs. Now, we don't see these people because you call the cath lab, you give them your cocktail, and they go upstairs, and you never get feedback. 5 times more common in women. We talked about women at the front of this talk, that we've been screwing around in terms of our diagnosis of women for a long time. But MINOCA is big time more common in women. And the key is when they cath them, they find nothing, less than 50%, and no obvious overt cardiac cause. I want to tell you what I think the most important cause of MINOCA is that you need to listen about. I think this is the game changer for you today in terms of changing your practice, in terms of listening to patients, in terms of listening to women, in terms of being able to be there and advocate for your patients. This woman changed my career. She's 33 years old. She's 36 hours postpartum. She's had 5 kids. And 5 kids in Canada mean you go home after your baby pretty soon after because you have 4 other to look after and you're a superhero. She came in and looked terrible. Her vitals were normal. She was not hypoxic. She was not tachycardic. And the chief complaint was postpartum chest pain. I'm a pretty good expert in postpartum chest pain. My differential pretty much is you have a pulmonary embolism. They all do. And maybe a 3rd trimester dissection. And I'm pretty good at that too. But hey, she doesn't look like a dissection. She's not colic. But she doesn't look too good either. Let me take a peek at her cardiogram. Crap. I wasn't expecting that. I was looking for that right axis deviation. I was looking for S1Q3, T3. I was looking for AVR. But I'm looking at this and saying, that's not what I want to see. She's got significant ST elevation. I'm really worried about her. This is the 3rd time. This is the final time. Make sure you're 6 feet or 2 meters from the person beside you. And on the count of 3, I want you to loudly yell out what this woman's diagnosis. She's 33. She looks like a STEMI. Her ECG looks like a STEMI, but she's 33. She's 36 hours postpartum. She's a grand multip, and her ECG looks terrible. 1, 2, 3. I heard it. I heard it quiet from those people in the front. Those people who always are in the front, like the Roberto Cosentinis and people like that. I saw it. I heard it. She had SCAD. SCAD. When you Google search SCAD, it comes up as the Savannah College in Art and Design. It doesn't even come up right away. It's time for a rebrand. SCAD is spontaneous coronary artery dissection, and you can't keep missing SCAD. SCAD is kind of like a dissection, but it's just of your coronary. It's spontaneous, meaning it's not iatrogenic. It's not a cath lab complications. 30% present as a STEMI, 70% as a non-STEMI. It represents about 1 to 4% of ACS angiograms. We don't get this feedback, and it's an intramural tear that just propagates and represents about 32 to 46% of all LADs. Sorry, when you will see this affecting the LAD 32 to 46% of the time. There's no troponin negative SCAD. You will get the great ECG, you will get the great biomarker, and you will also get the great history, and they present with chest pain. They present with everything. Nausea, sweatiness, they look like a STEMI. They don't look like anything else. You don't see trope negative SCAD, but they don't look phenotypically like your acute MIs. They just don't look the same. You need to know who to suspect. It's going to be so important. These are the poster women for SCAD. SCAD has a mean age of 43. Only 91% of them are under the age of 65. This is a young person's problem, but 43 is the mean age. 85 to 94% are women, and this represents almost 40% of MIs in women under 50. If you see a woman with an MI under 50 who looks healthy and doesn't have history and doesn't have risk factors and doesn't use coke and isn't marfanoid, you got to think SCAD. You have to think SCAD. This is a dissection. This is not a thrombus. The key also thing is pregnancy-associated SCAD. The woman who changed my career was a 33-year-old, 36-hour grand mal tip, 5 kids postpartum. During pregnancy, the coronary arteries have estrogen and progesterone receptors that weaken. They weaken throughout the duration of the pregnancy, and they weaken with subsequent pregnancies, so that it's really highly advisable not to have children again, because it's so likely you're going to have a recurrence. It represents about 2 out of 100,000 pregnancies, and 75% of the time it occurs postpartum up to 6 weeks. 10% of them are grand mal tips, and this pregnancy-associated SCAD represents about 8% of all SCAD. It is a problem, and SCAD that's pregnancy-associated actually do much worse than non-pregnancy-associated SCAD. They're typically LAD, they're longer segments, and they're much more likely to be STEMIs, like our woman, than non-STEMIs. It's a big problem. And you have to respect hormones, because this is a hormonal phenomenon. We see it in people who start the pill, we see it in pregnancy, postpartum, and the other interesting group, there's 2. We see it in women who stop breastfeeding. So there's a tremendous surge as breastfeeding stops, and that might be at 6 weeks, 2 months, 8 months, a year, 2 years longer. Once they stop, that hormonal surge can cause SCAD. But there's one other one. And this one's hard as a speaker. My wife always tells me what to say. She said, "Don't go here, Dave." But menstrual angina. I don't even know. I mean, periods are terrible and I don't get any, but this is bad. That every time you get a period, you have angina, and that is a slight tear of your coronary. This is a problem. Hormones are a problem, and this gravely affects women. What we also know about SCAD is 60% will result and report a significant stressor. 40% will be emotional. That might be you just lost your job, you lost your partner, terrible thing happened, kind of in that stress catecholamine surge. And 20 to 25% will have a significant physical stressor, such as isometric lifting, or maybe you ran a half marathon, or maybe you just had a birth. But that's a key thing. And you guys all know me because you've heard me on the stage that I'm a simple person and everything comes as a pattern, is when you see ACS plus one of the following things. ACS plus a young woman with no cardiac risk factors. ACS plus a woman who is pregnant or postpartum, or ACS in someone who has a significant physical or emotional stress. You have to think SCAD. And remember, with the last one, you know, someone comes in, oh, I lost my loved one, oh, I got fired, I've had pain and palpitations, I don't feel well. These are the people that get blown off as, it's psych, it's not a problem. But no, you need to respect that significant emotional and physical stress, because it has a significant role here. And the reason why you need to know ACS plus one is because you need to plant the seed, because it's just not standard therapies. You need to get on the horn with your cardiologist. I work in the ivory tower. I have a cath lab right upstairs. But if you're transferring someone quite a ways away to have their care, you may not want to thrombolize them. Just like you don't want to thrombolize a dissection, you need to get on the horn with your cardiologist and have a discussion whether you think this is truly SCAD and whether your therapeutics should be altered. It is not standard ACS therapy. If you can avoid it, and sometimes these are real challenges because you might have a 6-hour delay, which you might have to go common versus non-common. But generally, dual antiplatelet therapy is reasonable. Maybe something like heparin that you would turn on that has the ability to turn off at the cath lab, but you really don't want to thrombolyse if you're at a center or you have to transport to a center without getting clearance. You want to plant the seed. And the reason you want to plant the seed is it's also angiographically not that easy. SCAD fits into 3 types. Type 1 is about 30%, and this is pathognomonic, and they see that double lumen. But when the angiographer goes in, she looks at the vessels and she should note if you've planted that seed, that, hey, I don't see thrombus. These don't look too atherosclerotic. This doesn't look like a vascular path. The emerge doc was worried about SCAD. He or she's onto something. The second type, which is about 65% of the time, is you see it almost like an intramural hematoma. And the third type, which is about 5% of the time, you can really get it fooled into thinking atherosclerotic. So in type 2 and type 3, you may get fooled, and they might need advanced intravascular ultrasound or OCT or other modalities, which are kind of above our heads, but you've planted the seed. You really want to get them to the cath lab because 70 to 90% will heal spontaneously. You want to do no harm. These are technically very prone to failure because they're long segments and very fragile vessels with 15 times increased risk of a iatrogenic dissection compared to regular vessels. And technical failure is big. These people have late complications about 5 to 10% of the time in the first week, so they typically stay longer. 13% of those who get PCI will go on to be CABG if they have significant disease. But unlike getting those 20-year new vessels when you have a CABG, unfortunately, the same disease process will affect these, and CABG doesn't solve your problems. You need to screen for other conditions. Typically, when the angiographer is done with the heart, they'll squeeze some dye into the renal artery, looking for this string of beads sign, or something that we see in fibromuscular dysplasia, which is a non-inflammatory disorder of vessels. And typically with SCAD, we want to CT them from brain to pelvis to look for aneurysms and abnormal vessels that we see in FMD. We also want to screen for other conditions, talk about hormones and pregnancy, but that's really not our bag. We need to realize that SCAD is bad. 20 to 29% recurrence. The mean recurrence is 2.8 years. And these people will continue to have pain because their artery is tearing. And they might not need to be re-angioed. That's just when you dissect, it hurts. SCAD sucks. We need to make a difference. We need to diagnose this. We need to listen to stories. So, 30 minutes. Tell you about one of the most important cases of my life. What can I tell you? Men and women are typical. Stop discounting women. Realize the gender-specific characteristics when you take a history, and start doing your patients a service. Ask patients like Dylan would say, how does it feel? Learn to take a history of STEMIs to find Stemi-Ish. When you think about PE, when you think Wellens, and you're going down that ACS path, and you see that Wellens +1, that T-wave inversion in Lee3, you got your PE. And think in SCAD about ACS +1. ACS plus young women with no risk factors, ACS plus postpartum women, or ACS plus significant physical or hormonal stress. I want to see you next year. I want to see you in person. This isn't Lisbon, it's Australia, but I want to see you back there. Please, everyone, stay safe. Have a wonderful year. Thank you so much for your time.
Brilliant as ever, David. Thank you so much. And back to the audience responding to that, one of the comments was brilliant as ever. So educational. There were 2 questions. First one, can you rule out SCAD with a normal ECG?
Remember, probably SCAD is not, you don't see troponin negative. SCAD should present like a STEMI or non-STEMI. So if someone has a normal ECG, you should think about other etiologies, just like any EKG. One EKG begets another. So if you're still thinking it, I would do another ECG, but a perfectly normal EKG and a perfectly normal troponin is a perfectly normal other cause of chest pain in that patient.
Great. Okay. And then just quickly, the other question that we had, do you ever use a D-dimer to differentiate a pulmonary embolism, dissection, or SCAD? Because of course it can rise with both.
Okay, I think that would be kind of like the American equivalent of a triple rule out where you do a CTPE dissection and coronary score. No, we can't do it for all that. Look, I think the most validated literature for D-dimers exists in pulmonary embolism, and I think that's where we're most comfortable to rule it out. We have not used it for SCAD. Remember, SCAD, there's a real paucity of literature, and in fact, it's really a relatively new discussion that people have been talking about, and that's why I want to amplify it. With dissection, that's a whole talk for itself if you want me to tell you about dissection and dimer. But I think we're not there to use it for SCAD and dissection, but certainly for PE, keep using it.
Terrific. Very clear answers. Thanks a lot, David.